Yes, hello, welcome everybody to this, I think, more final session of today, of this Monday on London Valves. So, as you can see, the title of this session is The Many Faces of Complex TAVI. So we try and we hope we can talk you through some complex cases and how the Evolute platform can be useful in this and how to master this technology in these complex situations. So I'm having the help from a brilliant faculty here. I have Angela, I have Ignacio and Haim, who's going to help me coming through this session. So let me immediately show you what kind of complexities we're going to tackle. We have only 1 hour. We can talk a whole day or a whole week about complex TAVI. But these are the particular cases we're going to address. We're going to have to show you some complexity about how to deal with challenging aortas, also horizontal aorta, also bicuspid. We have quite some focus on bicuspid, and I think that's some complexity that everybody faces in all everybody's practice. And bicuspid, as you can see, it has really many faces on itself. Bicuspid and bicuspid is not the same. There's many different types. And then also how to do post-TAVI PCI now, especially in the light of the Evolute FX, the new Evolute with the larger window. So I think we go straight to Angela. Yes, you're gonna tell us a case or share a case with us about horizontal aorta.
Yeah, great. So thanks so much, Ole. So I'm going to share a case on horizontal aorta. My name is Angela McInerney. I'm from Galway University Hospital in Ireland. So these are my disclosures. So we're going to talk about an 83-year-old gentleman, so quite typical TAVI patient. He has hypertension, he has lung disease with COPD, he's had multi-vessel PCI in the past, he also has an ischemic cardiomyopathy with a reduced ejection fraction, and he also has atrial fibrillation, so I think quite a typical patient of what we might see in an older generation undergoing TAVI. So he was in acute admission to hospital with increasing shortness of breath on exertion. He was NYHA class 3 and had decompensated heart failure on clinical examination. His echo showed a reduced ejection fraction at 20% and a very calcified trileaflet aortic valve. But his mean gradient across the valve was only 20. We were quite suspicious that this was low flow, low gradient, severe aortic stenosis, given his presentation. And so he went on to have a dobutamine stress echo, where his LVOT VTI did increase by greater than 20%, and we ultimately had a Vmax of greater than 4 meters per second. So our imaging colleagues were quite happy to call this severe aortic stenosis, low flow, low gradient, severe AS. So we continued then with our TAVI planning, which of course included a CT scan. These are his measurements from his CT. You can see that his perimeter of his annulus is 90. His sinuses are quite generous with a mean diameter of 39 millimeters. His LVOT actually gets larger, doesn't really narrow. And you can see that he has significant calcification of the valve, and that it's really quite symmetrical calcification across the 3 leaflets. But what you can also see is that he does have an angulated aorta. His aortic angle is 72 degrees, and you can see from the S-curve as well that he's kind of got quite a vertical S-curve, which does signify to you that he has quite angulated anatomy. So these are the views that we predict on CT scan for implantation: coplanar view of LAO 11, caudal 4, and cusp overlap view of RAO 6, caudal 40. We also looked at his coronary heights, which were more than satisfactory. Left coronary was 18, right coronary was 24, so no concerns there. And then we look at his iliofemoral access, and you can see that he has quite calcified disease in his iliac and femoral arteries. You can also see a big sort of calcification at the right femoral. The left femoral looks a little bit more favourable. Both of them are a little bit tortuous, although the calibre is quite reasonable. So we went on and had a heart team discussion about this patient over 80s. Generally in our hospital they go for TAVI unless there's really any other mitigating circumstances that they shouldn't, and so it was a short discussion and he was decided that he should be for a TAVI. So this was our
Angela,
procedural
before
plan.
you continue there, because we're in forum 2 here, maybe we could ask, I know we have limited time, but we could ask the audience if there are some outspoken preferences. Having seen this anatomy now, I think with the complexities about this, you have a large annulus, pretty elliptical, and you also have a horizontal aorta. Yes? So is there anybody, maybe you can see in the audience, who is willing to share his opinion about this case, what strategy he would use? Now you see here already the strategy that Angela did in her center, but anybody else who has a specific preference on this?
Yeah, I think there is someone here.
Yeah, please.
Oh, you didn't raise your hand, I know, but...
I think this anatomy looks quite favorable for TAVI, and I think in our institution we prefer the same. And valve choice, it looks like it could be any of the valves. It could be suitable for any of the valves.
Okay, good. Thank you.
Maybe here in the first row there was also somebody. Ignacio? Yes? Here,
yeah,
right in front of you.
All right.
Hold the box close to your mouth, please. And,
So I agree 34 should be fine, but it's very horizontal, and I'd like to see if predilation was done. Sometime that sheds more light on how the valve is going to behave, especially with evolute and other forms that do not have a flexible sheath. Sometimes it could be extremely challenging. And not too long ago, I had a very horizontal aorta. We put a 34, patient had in aortic dissection. We had to put a second valve after we clipped the leaflets, bail ourselves out. So that would be one very important consideration, using a very large platform like a 34 in an extremely horizontal route.
Okay, but I think maybe Angela comes to talk about some tips and tricks. Maybe just by hand raising, is there anybody who feels that you need for this particular case a steerable system? It's better with a steerable system to get here, probably a balloon expandable then. Who would go for that? Not too many.
Yeah, we have one of them.
What about wire selection?
Yeah, but then maybe Angela can talk about this. Let you go through the case, because we have indeed limited time, but it's a good remark. Yes, wire selection can be one of them.
Yeah, absolutely. So I think these are good points, and actually the idea here is not to show you the perfect case. I think everything is up for discussion here. So, you know, our plan was to use left femoral arterial access, and I think really, you know, we can do a lot of pre-procedural assessment on the CT scan, and we can measure the aortic angles, etc. But ultimately, when you're in the procedure, it's actually an accumulation of all the angles that you're dealing with, and you'll see in this case as well that even though we already knew we had a horizontal aorta here, it looks a lot more horizontal during the procedure once you've sort of straightened out all of the other kinks as you're going up the femorals and the aorta in general. So we were going to use left femoral arterial access as our therapeutic access, close it with 1 ProGlide and an 8 French angioseal if we achieved hemostasis, which is our normal practice. We usually pace on the wire, and actually we use a safari wire usually. So I think you can kind of debate that, whether or not a double curve Lunderquist would be more useful in this particular case. We're quite comfortable with the safari wire, and we use it in, I would say, 95% of our cases. And then often when we have difficult cases, we tend to rely on the things that we're used to, actually, rather than changing to different wires. We pre-dilated with a 22 millimeter balloon, or that was the plan, and you can also kind of argue whether or not we should have gone a little bit larger with that, because we had a minimum diameter of 24, and we are about to implant a really large valve. So there is some utility in going a little bit larger with your pre-dilatation, so that you can make your procedure a little bit easier. And then, of course, this was an Evolute FX 34 millimeter. This was done a couple of months ago, so we didn't have FX Plus back then. And if we needed to post-dilate, we would either use a 24 or a 25 millimeter non-compliant balloon, but probably a 24 just to respect the anatomy that we were already dealing with. So we began with pre-dilatation, and I think you can see kind of with the wire that actually, even though we knew this was an angulated aorta, it does actually look a lot more horizontal once everything else has been straightened out with the stiff wire. But we pre-dilated quite nicely with a 22 millimeter balloon, and then began to advance the FX system. And the FX system is a lot more lubricious than the previous iterations that we had. So you can see in this kind of tortuous, quite calcified anatomy that it does actually pass through the iliofemoral junction quite easily. And then, of course, we aim for commissural alignment in all cases, and you can see that even though the aorta was quite horizontal, the Evolute FX, this is us getting the hat marker on the outer curve here, and then bringing it around the aortic arch, which we really had no difficulties with. So we started off with our first deployment, obviously in cusp overlap view. And this was the first release of the valve, and you can see from our oreocaudal view that actually we felt that this was a little bit too deep. So we can discuss that as well, because we had no conduction disorders here. We had a very horizontal anatomy, but really we felt we were probably at about 6 millimeters here, which isn't really where we would want to be in terms of depth. And with all of these patients, if we don't get a perfect position on the first go, if the patient's stable, we will do at least one recapture to attempt to get a higher position.
No, Angela, indeed, I mean, the assessment you have to make in this middle, this loop, you see, you're at 6 millimeters. You're definitely deeper on the left side, yes? And then you're working with the 34 valve. You see that your delivery system is completely on the inner curve. So what people don't assess enough in their estimation, am I too deep or not? You have to think if this valve gets released from the catheter, it will always follow the aorta, yes? Yeah. So it will definitely tilt in that way. So this non-coronary cusp side will come lower. So this is absolutely not a good depth to release for me.
Exactly. Yeah. And I think we felt the same, and this patient was very stable, so we felt that we should recapture this valve, probably try to get a better wire position and see if we can tilt the whole delivery system a little bit more on the outer curve. So this is our second attempt, and you can see we are actually much higher. The 34 millimeter will always kind of want to dive in a little bit, so you do have to get a nice wire position and a very kind of steady position and try to bring it a little bit more onto the outer curve, which I think we are marginally more on the outer curve in this second deployment. And then when we take an angiogram in the oreocaudal cusp overlap view, we can see here that actually this depth is much more favorable. I think we're really just at the marker 3 millimeters here. And then looking at the isolated left coronary cusp view here as well, you can see that our depth on the other side is also satisfactory, I think.
Also, your delivery system is much more central in the aorta, which is also a good sign. Yes? So the valve will tilt less than in your initial inner curve delivery catheter position. Yeah.
And I think with the Evolut FX, the delivery system does sit a little bit more central than what used to always be on the outer curve.
Better and opens up in a more symmetric manner.
So we were happy with this position, so we'd actually just finished off with our final deployment. These are just little markers to show you where we felt we were in the depth. So this is our final release. We did do a hemodynamic assessment after this. We thought the diastolic was a little low and that maybe the valve was ever so slightly underexpanded. So we went straight to a post-dilatation without taking an aortogram. And this is a 24 millimeter non-compliant balloon. You can see we have put a temporary pacing wire in here, which we normally pace on the wire, but actually just in this particular case, we like to take off the tension off the wire, and we weren't getting full capture, and for the post-dilatation, we really want full capture, so we put in a temporary pacing wire just to post-dilate this patient. And then this is our final aortogram. You can see, of course, it's a horizontal anatomy. This is our transvalvular hemodynamics, where we've no residual transvalvular gradient and we've no evidence of paravalvular leak. So this patient went home the following day. We closed the femoral with 1 ProGlide, 1 8 French angioseel, no complications, no conduction disorders, and a really nice result, I think. So this is our experience in Galway of the Evolut FX. We feel that it does navigate tortuous anatomy better than the previous iterations of Evolut. Obviously, with the markers, you have more accurate depth assessment, and commissural alignment is much easier. Not 100%, but it's certainly much easier than before we had the markers. And then you definitely get this much more coaxial deployment, as we were speaking about. So your depth on the non-coronary cusp is often the same as your depth on the left coronary cusp, and I think this is a very welcome change from previous devices.
Yep. Yeah. Perfect. Thank you, Angela. A very nice case, and I think we had already some discussion during the case. So I think I just, also for the sake of time, I just continue with also an aortic challenge, in a way, I would say, and that's the following. Sorry, this one. Yeah. So what are challenging aortas? Well, horizontal aorta is one aspect. That's at the end of the aorta challenge, I would say. But there are other complexities you can face on the way up to your aortic valve. First, extremely tortuous descending aorta. You have sometimes these extreme tortuosities, aortic aneurysms. You have a severely angulated Gothic aortic arch, yes, especially in combination with sometimes bicuspid or sometimes a coarctatio-like aortic arch, where you have to be careful with. And also, that's something I want to talk more in detail here. Aortic arches with severe calcifications or atheromas. I'm sure many of us, we miss it. We look to the axis, we look to the valve, but how many of you, maybe by raising hand, how many of you systematically looks for the arch and looks if there is a lot of soft plaque or calcifications? Who does this systematically? More than I thought.
If you ask who doesn't, nobody's going to raise.
But I'm not
hands.
sure if they really do it in real practice. I want to see that, but that seems like half of people still do it. Well, okay, but that's good. That's good. But I would say in all, if I have to face these complexities of aortas, I love to use a long dry seal sheet. Yes, and that's something I use since 2-3 years, and it really takes out all the complexity. So what you do is you just wire up with a regular wire, catheter, up to the ascending aorta, take a Lundquist wire, and then very atraumatic, and it's a very flexible sheet. I know that the FX and the FX Plus is already an extreme flexible device, but that's not what it is about. It's really avoiding interaction and with all this, and even your one-to-one feel of the valve, what it does at the aortic valve level improves there. So I want to show you a couple. This is, for example, severely angulated Gothic aortic arch. For me, that would be already enough if I plan to use an evolute system, even the FX or FX Plus. I would probably go with a long sheet. So here, this you see here. I would have better done this in an LAO, but anyway, this is in a kind of a cuspola. But you see here, this is the stiff wire. It's already stiff wire in the ventricle here, by the way. And then the long, it's a 65 centimeter long dry seal, 18 French sheet that goes in there. And then you see, this is the beauty. Then you avoid all interaction with, even if you have very complex aortas, you have a very shaggy aorta, you avoid all this interaction, and you already exit the sheet in the ascending aorta. Then it's up to you to decide whether, if you are at the level of the aortic valve, whether you retract the dry seal to the descending aorta, yes or no. That depends. Sometimes I do, sometimes I don't. Then you do your implant of evolute, great results. And this is what I want to show from the shaggy aorta. So you see here, for example, keep an eye on this left upper panel. So this is an aortic arch full of soft plaque calcifications. This is definitely a patient at risk for stroke. I mean, and I think we underappreciate that the risk that is related to crossing these arches. I do already since 2015 all my TAVI procedures purely in local anesthesia. So the patient, I can talk with him during the TAVI. I can tell you the worst strokes I've had, and that's not too many in my life, but I had a couple of disabling strokes. That's typically after crossing the arch. Yes, I know the time when the patient has a stroke because there sits a nurse next to the patient when the patient is not relevant anymore. So with pre-dilatation, never had. Yes, pre-dilatation is a very safe act. I've never had a stroke related with this, but with crossing an arch, for sure 4 or 5 of disabling strokes. There's even a paper on this, I think from Jack Cardiovascular Intervention recently. So if you can protect there, I think you can protect more stroke by using this technique of using a long dry seal sheet than using a sentinel. And that's also what we do here. Now, I don't have you unfortunately this was not the case done, but you see the long sheet going up there. I can tell you that it was a long dry seal sheet. A regular sheet would never come that high up. So I don't have the full images of the whole open sheet here. This was an evolute FX. I guess I post-dilated further, I think here. This is then a nice high implant with a good result. And then here, this is what I can share with you. So I looked at it the last 2-3 years. As I told you, I use of 65 centimeter long dry seal sheet in 125 plus challenging aortic and high stroke risk cases. So for me, that means challenging aortas, Gothic arches, etc., patients at risk for dissection. And I've seen here at this meeting in London Valves quite some cases. Sometimes people show some cases they do where they do all kind of crazy maneuvers in these aorta to cross with any platform. I think that's very often unnecessary. Just place a long sheet there, and you can avoid all these complexities and these risks you take on aortic dissection. So you see in these 125 plus challenging cases, easy TAVI delivery. I had 0 vascular complications, no dissections. I had still in high risk population, only 2 non-disabling strokes in a very high risk stroke cohort. And there's, as I told you, improved one-to-one depth control of your TAVI because you take also all these tortuosities and store tension in your catheter out of the equation. So that's just what I wanted to share with you on how to tackle challenging aortic anatomies. Maybe Are some of you in the audience maybe using this also, these long sheets for some cases?
Actually, Ole, it's quite difficult to get them because you have all of them in Copenhagen.
Yeah.
Meanwhile, Ole,
Any question?
Yeah.
Any comment?
you're paying in vascular diameter. You need larger vessels. I mean,
not a lot. I mean, look, the 23, 26, 29 Evolute fit in an 18 French. Yes.
Right.
For the 34, you have to. If you want to use this technique, it's a 22 French. But honestly, I mean, the price you pay for that larger access, it never let me. I mean, that never.
So
let me
you'll
pay
take
price.
borderline vessels as well, the 5 millimeters.
Yeah,
I mean,
for 18
the
French,
Evolute
yes.
are a default in those borderline vessels. Then,
but if I'm very transparent, I use very often, even for regular cases, I don't like to necessarily always make an exchange for a sheet in, balloon, system in, out, sheet in again. I mean, every time you pass a ProGlide, you increase the risk of failure of your suture.
definitely there are advantages to this technique. Yeah. You don't need the exchanges if you need to do pre-balloon, post-balloon.
But and look, these are very challenging cases, of course, where I use these long sheets for really challenging aortas. Again, I'm sure that an FX now with its better will track it, but you do it in a safer way. Yes, that's the message I want to give.
And what about this alternative that is very commonly used in Asia because of the bicuspid cases of directly advancing with the snare? You think that'd be similarly useful, or you
exactly? Also, all this use of snares and etc. I mean, of course, it's different. Like a very challenging horizontal aorta, where it's difficult to cross there for a valve-in-valve or a bicuspid type 1 right non-fusion or so. Then you maybe still need sometimes more tricky or more advanced techniques like with the snare. But everything up to the ascending aorta, the beginning of the ascending aorta, you can tackle everything with a...
And then it negates the need for a body wire, and maybe actually you can use softer wire. We spoke about whether you'll take a Lunderquist, and I mean, in your case, Angela, I would definitely. I mean, tortuous aortas, tortuous vessels, I would vote for a Lunderquist, and I guess that most of the audience will go for a Lunderquist. Maybe with the dry seal, you don't need such a...
Well, no, because the long dry seal doesn't take away the complexity at the aortic valve level, because you stop typically at the top of the ascending aorta. So if you have something challenging still at the valve level...
On the other hand, it kind of straightened the femorals.
Yeah,
and
you have sometimes more
you earn some more pushability.
Yeah, absolutely. So let's continue, because of course we have limited time. Haim, you're the first speaker on the bicuspid topic.
Okay, so I'll present, and I'm starting quoting you that not all bicuspids were born the same. And I think that we cannot look at all bicuspids as a kind of the same basket, but different. And here is a very nice gentleman, a teacher, 65-year-old, very young guy, after a resection of a spinal tumor, partial mobility, morbidly obese. You see the BMI, cannot actually exercise and just gaining weight, severe shortness of breath, severe dyspnea, and these are the parameters for his severe aortic stenosis, aortic valve area of 0.6 square centimeters, a mean gradient of 75, and you've got the measurements. This is the annulus, a minimum of 27, max 31. On average, the annulus is 29, area derived or perimeter derived, all above 29. You see the area perimeter of 92, which actually corresponds with a 34 parameter. And here you can see the calcium dispersion, highly calcified. The Agatston score was above 6,000. And you can see here the fusion, the raphe between the right and left cusps. What do you do now?
We can ask the audience there also.
I'm not even showing the vessels, excellent vessels, quite straight. He's a young guy, and we'll touch on the vessels
you have
at the end.
young patients. Important.
Young patient.
So lifetime management is important. You have a bicuspid, type 1, a calcified raphe, and it's a large annulus. So maybe you have
What's the ICD? It looked pretty constricted and a very calcified raphe between the right and the left. So your anchor really is going to be right at the leaflet level. So you're going to have to decide what your ICD is, and that may go for a much smaller platform relative to...
So the ICD was about 27, but a very small area, and different measurements at 4, 6, 8 millimeters, and therefore I'm not showing all of them. Tough to deal with.
Oh, what's the reason he couldn't be a surgical candidate? Did he have some...
Immobile, after this spinal tumor, morbidly obese, restrictive lung disease. The surgeons brought him back, actually was referred by surgeons.
Okay, good. So any other opinions? What strong opinions here? Maybe I see there a face I'm familiar with. Maybe what would you do in this case? Hold the box close to your mouth.
Yeah. No, I think you've been through the clinical assessment. I think it seems to be a good candidate, or from a clinical standpoint, I would agree that it would be a good candidate for TAVI. Mm-hmm. But I believe, as you also indicated, it's quite difficult to try and assess the valve itself. But I would go through the different heights and try and assess where can I expect to acquire sealing. Mm-hmm. Try, in general, to place the valve high and go down in size, not use the annulus itself as the only marker for my choice of valve, at least.
Yeah. So would you do balloon sizing?
I would probably use the balloon as well, semi-compliant, and see how it influenced. It was influenced by the valve itself. Yes.
Mm-hmm. I think it's an excellent point, the use of a semi-compliant and not
but at
the non-compliant one. We'd like to see whether there is an indentation, a waste on the balloon, and at what height, and then learn from that.
You have a young patient. Is there anybody who has strong feelings? So first you have to decide on the valve type. Yes, you want to do. So anybody who wants to share his opinion about, maybe you
have
can
another comment over here, Ole.
Sorry?
You have a comment over here?
Where?
I mean, we have a calcific raphe, so in this case, maybe you want to choose a self-expanding platform. I think you have to decide what's your sizing strategy here. If you want to size at the annulus, or if you want to take extra supraannular measurement. In our center, we use the LIRA method, measuring the perimeter at the level of the maximum protrusion of the raphe. Mm-hmm. So in this case, maybe if you have a tapered anatomy with the perimeter at the LIRA smaller than the perimeter at the annulus, you might choose for a smaller size prosthesis.
Yeah, so it's definitely true. I mean, if you do bicuspid treatments for any valve you do, you need much better assessment. It's not enough with just your annulus level. Maybe you show that. Do you have more CT images?
I tried to make this, to simplify the case, and what I said here, we did analysis at different levels and couldn't come up with a decent, size, and therefore what we did is we decided to rely on balloon sizing. Mm-hmm. And here is a 23 balloon. Ooh. As you can see, semi-compliant. We learn a lot. We see where is the neck, the waist, and then as you can see, once you inflate the 23, it fractures. So we know now that the 23 actually, as you can see here, we're just injecting, give excellent sealing, but ruptures easily, and therefore we brought a new balloon, repeated this inflation. Now it inflates well, and yet there still keeps the sealing, and there is a waist at about 4 millimeters higher than the annulus. Mm-hmm. And now we believe once you see that the 23 provides you with good sealing, we definitely downsize. We downsize just by 1 to a 29. That's still the Evolute Pro, so it's not even the FX. Actually, transition was very well. And as you can see here, very high deployment. That's at 1/3. Here it is. PNR is the point of no release.
Yeah, and you see on
no return from.
Yeah, you see on the left side, that's your right-left overlap view, yes? Because
exactly.
you're sure about it because you're descending and ascending aorta or superposing, and you see how constrained your valve is there. And that's normal because it's the right-left cusp overlap. So that's where your RAFI is. Your RAFI is completely on the right-hand side of your valve. So it's probably the correct size of
the correct size, and that's at release. And yet, what we've seen, it was still too constrained. There was a gradient of about 15 millimeters of mercury. We did do the measurements, and therefore, and there is still decent paravalvular leak, or there is a leak. You can't really judge whether it's intravalvular or paravalvular, and then 23 balloon post-dilatation, of course, fast pacing, and here is the final injection, no gradient, and I can actually give you a follow-up of over 4 years now with this guy. No gradient even at 4 years, and no paravalvular leak. From a different projection. And just in curiosity, you can see here excellent vessels, and yet following proglide and an angioceal, there is stenosis. Always, if you can, do a final injection of the femorals. It was dilated with a balloon, and the patient did very well.
Well, that's very nice what you show, and I'm sure, for example, the case you showed, it's extremely still underexpanded in the inflow part. Yes, you see it. You have still a very constrained.
I'm sure it is.
Yeah. So what? Maybe if we can show the smart screen. Yes. We have actually. It's not published yet, but we have collected 200 post-evolute and bicuspid CT scans. Yes. And I can share with you that, of course, if we have the smart screen, can we share the smart screen? So if you look, of course, at some valves, we have clearly at the inflow part, node 0, node 1, sometimes the evolute platform is indeed sitting, especially if the RAFI, if this is your case, for example, with the RAFI there, you may have at the inflow part the valve, which is absolutely an expansion of around 70%, and also quite some eccentricity. You see this in some cases. It's all bicuspid cases. But then if we look to node 4, node 6, where actually the leaflet is sitting, and that's the great thing. That's why I personally really am a strong believer and a user of evolute and bicuspid, because it's really a concern for me having all these underexpanded valves. Sorry, if you have an intra and a leaflet position, underexpansion and eccentricity. There's a recent paper from the Cedar-Sinai group. They show it's related exponential increase of leaflet thickening, leaflet thrombosis, and these patients have late strokes. Yes. Well, that's not what we see in the evolute. In the evolute, we see in all these 200 post-evolute CT scans that actually at the level of where the leaflets are, these valves are nice circular and 95% expanded, even if the inflow is underexpanded and very eccentric. So that's a beauty, I think, of this system. These leaflets are kind of safeguarded high in a nest, like in a tree, you know. So that's a good thing. So I wouldn't be concerned about underexpansion.
That's exactly why I think that indeed the evolute is the right valve for those highly calcified. The supraannularity of it allows the functioning valve at node 4-6 and not
exactly
at the
so very nice case, and you showed indeed that sometimes, first of all, balloon sizing can be helpful. I do agree on that as well. We try to do as good as possible an assessment on CT, but sometimes you have these doubtful cases. It's not bad to do maybe intra-procedurally still some balloon sizing. That's absolutely helpful sometimes, and that downsizing also can be helpful indeed. So maybe we continue. Yes, I think now, Ignacio, you have another bicuspid case, isn't it?
Yeah.
For us.
We do. So let's move to the next one. And if
any comments or anybody wants to say something on the cases, please do.
This is another bicuspid case. I used the same setting as Angela because this was very beautiful with the antecedents. diabetes, severe COPD, so she's a young female, 78, but with some comorbidities, a prior PCI to the right coronary artery, and quite calcified ascending aorta. So not a very good candidate for surgery, though. We checked the coronaries. Left coronary artery was okay. Right coronary artery presented a stenosis of the proximal segment, as you can see here. So it was treated first with lithotripsy, second scoring balloon, and third drug-coated balloon. And this was the result. That was nice. You can see already the calcification in the aorta. So this is the case. The intercommissural raphe distance was within the range for a 29. The diameter derived from the perimeter was also within a 29. But I was jealous of Ole because he was drawing very nicely. So I also want to draw a little bit about the case. If we can show the blackboard, please. So the idea here is that we have this raphe here and the commissures. So we can use several methods. So here you could see how we measure the raphe. We use also the circle method. Circle method is just in the aortic annulus, we will simulate the 29 valve to make sure which is the risk of annular rupture. And then we will also simulate the 29, or if we want to change the size, the 26, and see which is the risk of paravalvular leak in this patient. This is the circle method. But then finally, we will need to consider also the raphe. I know Ole will explain this later in detail, but the calcification and the length of the raphe might lead us to undersize. So in our patient, we were in the lower range for 29, but we decided to go on with 29 in the patient.
Maybe, Ignacio, before you go further on what you did, I mean, is anybody anticipating an additional complexity in this case? If you have a type 1 bicuspid with a raphe between the right and the non-cusp, what's the additional complexity? Can anybody say this? Yes?
For the wire?
Exactly.
Yeah.
So the problem is, with these cases, you have to know if you do TAVI and you cross the arch, if you have a classical wire position, yes, the wire typically indeed always sits into the commissure. Yeah, I should take a color. Sits in the commissure. Yeah, that's not a good color. Or maybe I should use a pencil. Sits in the commissure between the right and the non. Yes, because this is should resemble the non-coronary cusp, the right coronary cusp, and the left coronary cusp. So your wire, for any platform use, if you cross the arch, the wire sits in the commissure between the right and non. The problem is, if it's a raphe and it's a bicuspid there, your wire, first of all, you will see that the wire sometimes, if I can go further,
looks different than what you're anticipating.
Yes, indeed. If you have your aorta like this, yes, here, typically your wire lays like this into the ventricle. That will not be the case in these cases. Very often, because the raphe is there, the wire will be such a bit lifted up. That's already annoying. And that makes that very often in these cases, you bump against the raphe when you want to cross. And you have actually really trouble getting across. So that means you have to predilate really, really, really good. I mean, honestly, you have to make sure you predilate, maybe double tap predil. You maybe use a stiffer wire, maybe I'm curious to see what you did.
Every once in a while, even the regular balloon wouldn't cross here. These are the cases in which you need tinier balloon, go even with 8 millimeters at the beginning, peripheral small balloons, otherwise it wouldn't jump.
You can anticipate this, yes? If you have a type 1 right non, be careful with these cases. But I'm curious to see what you did.
Yeah, so all are technical challenges, but first we need to choose the size.
Yeah, true.
Halim selected undersizing a little bit, and in this case we decided to proceed with 29. Do you agree with that? Would you undersize in this case? Because the raphe is ugly. So we would, come on, someone would put 26? We go for 29, 126. You want to explain why, the reasons you might have?
I may be worried about the calcified raphe, how long it is, and about the risk of annular rupture.
Okay.
And then still the 26 can be post-dilated. So maybe 26, I would consider this definitely.
But she's young, and risk of paravalvular leak is also there. So this is what you need to counterbalance.
Because Ignacio, your perimeter is more on the borderline between 26 and 29, yes? It's not that you have a perimeter of around 67 or something so. But okay, so anybody who would downsize here based on the information you have? I would maybe consider doing it.
I would consider, and I would do a balloon size here definitely at 22.
Yeah, but when you do balloon sizing, you mean having the valve ready, right? Or not?
No, in the case that I showed, this is the only exception in our practice in which we don't
make the prep.
We have two valves and we're ready.
Okay. We have a commenter from the audience.
For me, that's because it's a rapid, it cannot move. And when you use the self-spending valve, that's 26, that's upper part is maybe that's 23 to 24. And for 29 is around 24. So there's in this area, there's sometimes the paralytic is not sealed by the annulus, it's sealed by the supraannular part. So there's when you use 29, sometimes the valve will going down and going deep. So it's a big problem, especially when you pre-dilation the valve. So that's you must use 29 because everything was loosening.
Okay, so what you are afraid of? Okay, that's enough. So what you say is you're afraid of that it would dive down. Yes, if you go for an oversized valve, that's a fair enough comment. Another thing you see, what you show here on your image, actually the aorta is relatively large. So Ignacio, for that it could make sense to stick with the 29. But please continue. Yeah.
This is the case. So we started 3-cast view and 2-cast view injections. You could see the degree of calcification. We pre-dilated with a 20 balloon. We check for the commissural, which is coronary alignment in this case. We have to correct a little bit the orientation. This is the external curve. You see the heart marker will be all in the external curve in this view, so we are good. And in 2-cast view, we have the heart marker at the front, so we are aligned. We started deploying. This is a bit accelerated. I don't deploy so quickly, don't worry. We deployed. It was very high, just to avoid what the colleague mentioned in the audience, but we have a pop-up. So we did not predilate probably so hard. So it was partial. We recaptured. We went a little bit lower in the case, and we started again. So the deployment was stable. We tried to adjust. A lot of parallax, as it usually happens with these eccentric bicuspid cases. And we could see under expansion, but it suggested also some partial, I mean, the struts were not deploying correctly. So we decided to recapture and to do what you said.
Can I ask you one question, or is this a video that can let it play further? Let it play further. It's good. But what I always wonder, and I want to hear what others do. So you expand your valve in a cusp overlap. Fine. But then you see it opens up to 80% and there comes plenty of parallax in the valve. Yes, that happens sometimes. I don't stay in that strict cusp overlap. I mean, what I do then, that's the additional information you get. If you open it up a first time and you know you have to reposition, I will, before I resheet my valve, I will go to I will stay as close as possible to my cusp overlap, but I will go either a bit more caudal or take a bit of REO away.
For the parallax.
So take the parallax out, and then I will resheet and reposition. Because now you have parallax. Of course, the second time you open up, you also have plenty of parallax.
I agree.
Do you
it's
always
very
do that?
important to check in different projections, maybe change the projection for deployment, but I think the issue here was also the predilation was not enough.
No,
you have only used a 20, so we removed the system, we predilated again, so this was a mistake, and I think it's a key learning point of this case. We dilated with a 23 balloon, and we advanced the system again. We checked again for the coronary alignment, so we see the heart marker is correctly positioned, and we performed the deployment. But the issue here was also some degree of infolding. It's not an infolding because it's too large, but probably because of this very calcified raphe. Still, we decided to proceed. We performed the implant. The valve was stable, did not dive in the ventricle. We removed our delivery system, and then we checked in orthogonal projection. These rotational or orthogonal views are very helpful to decide how we treat. We post-dilated with the same 23 balloon, and in the final angiography that we'll see in a second, there was a mild paravalvular leak that we also checked by echo with a nice result. And then this was one of our first FX plus cases. We wanted to check the coronary reaccess. For the left, you see how quick it was. I know it's accelerated, but it was really, really quick just at the first attempt. And the reaccess was really easy. No issues. And then we tried with the Jatkin right. First attempt, it went in, but oh, surprise, surprise, we have treated the restenosis of the proximal right 1 month ago, and there is a restenosis. So luckily, in this young patient, we could reaccess in a very simple way, we could dilate again, and this time we chose a stent. No more DCB for the patient.
Beautiful.
So my lessons from this case, it's important the correct sizing. Maybe we went too far, but I think 29 was a good choice in the patient. But predilation has to be correctly aggressive in the patient as needed. Very important to assess under expansion in orthogonal views, maybe deploy changing the projection as Ole suggested. And we are talking about young patients here, the bicuspid ones, so aim for optimal hemodynamics and aim for optimal coronary reaccess. Thank you.
Great. Okay. I think that for the sake of time, we'll move ahead.
Yeah, maybe 2 minutes. If there's any comments, please raise your hand. But the fact that you had the infolding could be a sign that maybe the 26 would have also worked, yes? Because it probably did because you had all, I mean, it's very calcified, clearly. That led to it, and you see it more in bicuspids, but
we also have mild PV leaks, so maybe 26 might have been moderate, so we really need to counterbalance that.
No, absolutely, you have to balance these. But it again, predilatation is key, and not only for bicuspid, I already for years say predilatation is key, and it improves your expansion of your valve, stability with the final release. I don't think we should compromise on our predilatation. If we, for any valve almost, it's less needed for a balloon expandable because you place the valve with the balloon. Only in very calcified and bicuspid, still there could be reasons to do it. Yes,
absolutely.
I think that the point that you mentioned before need to be re-emphasized. We shouldn't stick only to the cusp overlap. Whenever the parallax is too extreme, change the view that you're working with. Otherwise, you may end up in a wrong.
Yes, indeed. It's good to start out with the cusp overlap, but if there comes plenty of parallax in, I mean, I correct for the parallax. Otherwise, it's.
And we do see it more with the bicuspid, and therefore look for the one in which it's corrected.
And now you didn't have a problem crossing there because of it was a raphe there with between the right and the non. But this is something to think of if you have really severely calcification, which can happen. Okay, I think indeed, due for sake of time, we continue with our last topic, and that's about PCI post-TAVI, yes, Haim?
Yeah, so we'll go.
Oh yeah, I still do this. Maybe shortly. Yeah, sorry about that. That's a small. That's to give you an overview of all the sizing. Now we talked a lot about bicuspid and how to size. There is coming up a review article on this, and I can give you. There's actually six approaches of how to size. First, of course, you have your classical annulus measurement, but this is, I give you the 6 approaches. First, intercommissural distance, that's based on the Bavard sizing method. So everybody knows that, whether it's a tube or a flared or a tapered anatomy, comparing the ICD, intercommissural distance, 4 millimeters above the aortic annulus. That's one sizing methodology. The other one is supraannular tracing. You can do this at 4 millimeter tracing. You can do it at 10 millimeter tracing. That's what they call the LIRA method. And then you anticipate actually the perimeter, the size of your valve. That's first two sizing methods. A third one, the circle method. That's very relevant for balloon expandable, but you can also use this if you do self-expanding. Yes, you just have to take into account, if you work with an evolute, that the 29, for example, becomes the wasted 23, so you have to take that into account. The Casper algorithm, that's from Sonia Petronio, where you do start out with your perimeter-derived mean diameter, and you subtract millimeter or a millimeter if the leaflet calcium is high, 1 millimeter extra if the raphe length is more than 50% of the annulus diameter, and an extra 0.5 millimeter if the raphe is calcified. So that's sizing method 3 and 4. And then number 5 and 6 is computational modeling. Yeah, you submit your CT to a company who does simulations, or the classical balloon sizing, as we discussed as well, good old style, but that still sometimes works. So that was just small intermezzo of the 6 sizing methodologies for bicuspid valves, and that's for any valve applicable.
We just
So
have
now,
a comment
Haim?
on that actually, Ole, over here.
Yes.
Sorry to interrupt, because I'm working in Sarafele Hospital who developed the LIRA method. I just wanted to clarify a point that the LIRA method doesn't measure the perimeter at a fixed level, but it measures the perimeter at the maximum protrusion of the raphe, where anchoring of the prosthesis is expected. So
Yeah.
we know that the raphe has not a standardized height, but it can vary from patient to patient. So I
But
think that
typically it's around 10 millimeters because that's where the RAF is.
I think even in our population, the RAF is quite high. Maybe we have a medium of 7 or 8 millimeter. But I think the most important point is that it's a tailored method, not a standardized. So you can really apply to each patient.
Yes.
Thank you.
Okay, good. So let's continue, Haim.
Okay, so I'm happy to present the new toy or new player in the field, and it's the Evolute FX Plus system. We know that many of our patients suffer from coronary artery disease. The rate varies in different series, reaching some up to 70 or 80% of the cases. And we know that many of our patients would need coronary cannulation following TAVI. Treating young patients, definitely the numbers would grow. Different series show that between 5 and 10% do reach angiography and angioplasty following procedures, with about 5% calling because of acute coronary syndrome and non-STEMI. Now, coronary cannulation may be complicated. Different factors are affecting the coronary cannulation, with the self-expanding and balloon expanding, and whether it's the frame, whether it's the anatomy, the distance of the coronary sinus width, and of course, the orientation of the valve in relation to the coronary ostia. We all follow currently the commissural alignment, which actually improves or provides us with a better access to the coronaries, not that difficult to attain, and yet we see that in some patients it may be somewhat challenging, even though we're doing the commissural alignment, and I wouldn't follow the different steps of these procedures. And for this actually comes the Evolute FX Plus, which enjoys all the advantages of the Evolute FX system with its flexibility and control, which allows a very predictable deployment. And in the Evolute FX Plus, we've got larger windows that are larger by 4 to enable future coronary access. We've got 3 of those windows. Each window is in the size of 4 normal frame cells, and all 3 are positioned at 120 degrees apart between the TAVI commissures. And these large cells allow for much easier cannulation. No struts are actually standing between the catheter and the coronary ostia. It actually provides us with a much easier, less challenging procedure to cannulate the coronaries. As you can see here, the size ranges in the different with the different bioprostheses, with the different evolutes, 23 up to 34. The size of the larger windows ranges between 21 up to 27 frames, different between the different frames, but in all of them very large. And as you can see here the height of the coronaries. It's indeed in front, at the level of the coronaries, whether it's the right or left, and therefore much easier cannulation, provide us with a much easier solution for this tackle. As you can see here, we do see the larger, in fluoroscopy, we do see the larger frame, and if we do follow the commissural alignment, we'll end up with these larger windows in front of the left and right, respectively. So after aligning, we move ahead to the procedure. And it's a small step, but yet, as Van Gogh is quoted, "Great things are done by a series of small things brought together," and I think that this small thing or enlarging thing definitely improves our ability to cannulate the coronaries. And when we discuss lifetime management and dealing with coronaries, treating young patients or elderly with coronaries, we do enjoy this capacity. And I would like to share with you in very short this young 68-year-old female that was treated about 2 months ago. As you can see here, my patient with metabolic syndrome, obese, BMI of 40, severe symptomatic aortic stenosis, mean gradient of 50, moderate pulmonary hypertension. Based on what we describe as the Becky-Hunt charts, she is at high risk for patient prosthesis mismatch with a balloon expandable, moderate risk with the Evolute, as you can see here, highly calcified valve, AV perimeter of 71, area of 378, either a Sapien 23 or 26 Evolute, non-obstructive coronary disease. We didn't even do an angio, but when she's 68, definitely she may need in a later age coronary angiography. Femorals are fine. How many of you would send this patient to surgery nowadays? She's 68, very high BMI, not willing to undergo surgery, and yet, raise of hands, how many in your practice would of these patients, such a patient would go for surgery?
Are your surgeons enlarging the annulus? That's the question, right?
But with the 26, she may do well anyway. After discussing this with our surgeons, with the patient and family, it was a decision made for TAVI, choice of valve system with large effective orifice area and low risk for patient prosthesis mismatch. And of course, coronary access, conscious sedation, local anesthesia and mild sedation. Right femoral artery access with a 14 French based on wire, Evolute FX Plus. At cusp overlap, you see it 4 millimeters deep. 3 cusp view, no parallax. Here we still leave the pigtail to see that indeed it was we deployed where we intended to deploy, and now supraaortic injection. No leak by echo as well, and we enjoy this capacity, as Ignatius showed, very easily cannulation of both the left main and the right coronary. And that was actually our first case of the FX Plus. Since then, we've done a few dozens, and in all cases, we do the coronary angiography. Mm-hmm. And there's always the question whether we should document this and tell and write in the file at which height and how is it going to be.
Exactly. I mean, in a way, before concluding, we have still kind of 3-4 minutes. I mean, what are you show very nicely the FX Plus clearly helps. Well, first of all, it's FX already, FX Plus to get commissural alignment. And then if now with the larger cells, facilitates coronary access. But what are your tips and tricks? Maybe Ignacio, Haim, maybe Angela as well. What are your tips and tricks there for facilitating your coronary access? Are there a couple of things, fluoroscopic view, switch catheters? What are some tips and tricks here?
Yep. So first, if you have the CT, you can predict the projections where you really have them where you want the coronary. And then for the left, normally we select with this valve JL4, for the right, Jatkin right 4, and that's our standard.
You don't downsize on your catheters like you say now JL4, or you do?
With FX Plus, we go for the 4. Yeah.
Okay. Angela?
I think it depends. Obviously, if you're doing a PCI, sometimes it can be a little bit easier to go left radial access in these patients, or even femoral. But again, we would probably do a JL4 and a JR4, and then an EBU with maybe even a guide cath extension inside it can be very useful if you're actually doing a PCI. But I think we've done a very much less than you in terms of the FX Plus, but we have cannulated the coronaries to document it after every one of them, and it is easy, and you can even see how the catheter behaves in the window. It has so much room to move even within the window. It's a very big difference. Yeah.
Yep. We used to downsize the catheters. Take a Judkins 3.5. Now, with the FX Plus, we realized that you can use the regular catheters. They go very well, and indeed, they're not stuck at the frame, but rather.
Yeah, that's the thing. That's maybe a good point. Now that you anticipate that you can easier go through, maybe you should just stick to your normal size of your catheter, yes, and not necessarily do the downsizing, indeed.
Yeah,
but indeed, I sometimes also wonder if we do all these cases and we start to do them, especially on younger patients, also like in the US, where your risk is that you see these patients back for invasive coronary angio, why don't we write some angles down in our TAVI protocol at the end that we say this is the optimal angle to get into your ostium of your left main, this is the best optimal first. You know this, you have that information at that moment because you have the CT. You can clearly look for your LCC, isolation view, RCI isolation view, so we could add easily this information in our procedural protocols in a way. That's something just to think about, yes.
Very good idea.
So I think with this, we came indeed to the end. We have 5 seconds, I see, so I'm going to take a little bit 2 more minutes, maybe. First of all, thanks for coming for the session. I hope this was a useful session to talk you through some complexities. We talked about horizontal aorta, challenging aortas, how to deal with them, some tips and tricks. Also bicuspid. Bicuspid is a very difficult field in a way, but a field where a lot of patients we are facing, and the more younger patients we are treating, the more bicuspids we see. Just to share from me, in my practice, 2023 in Copenhagen, where we treat already a bit younger patients, average age is still 77, but I see often also younger, it was 16%. 16% of my TAVI practice, almost 100 cases, are bicuspid. So everybody of us has a lot to deal with bicuspid cases. So it's important to all the considerations we make on under expansion, good expansion of the leaflet level, how downsize, not yes or no, the different sizing methodologies, and then finally also how to deal with coronary issues. And the FX Plus is definitely going to help in that, that's for sure. And I think there's still a lot to learn and still a lot of technological developments to come, I'm sure. But with this, I would like to complete this session, and I wish you a further good meeting here at London Valves. Yes.